Here to talk about what I consider to be the major difference between the obstetric model of delivering babies and the midwifery model of delivering babies. And the advantages to me, both with evidence-based medicine and common sense, are simply overwhelmingly on the side of the midwifery model of delivering babies. There's always a place for high-risk pregnancies and things where, treating women and treating pregnant mothers differently has to occur. But every pregnancy in the current obstetric model is treated as a possible disease or a possible medical problem from the minute they walk in the hospital. A woman's put in a wheelchair. They're brought up to a room. They're put in a hospital gown. They're put in a bed. They're strapped down to the bed with monitors. They get an IV. They have to ask permission to get up to go to the bathroom. It's completely stress-filled rather than stress-free. And stress, of course, and fear causes adrenaline release, which causes a dysfunctional labor pattern and leads to more interventions, such as epidurals and Pitocin, and then eventually either vacuums or forceps or C-sections for things that stalled out if Pitocin and other interventions don't work. Whereas if you take the midwifery model that pregnancy is a normal function of the woman's body and allow it to do its thing most of the time without having to follow a timetable or a curve, you will find that your outcomes, your patient satisfaction, your C-section rates, are all remarkably improved over the current obstetrical model. Vacuums and forceps and C-sections certainly have their place in the modern world of obstetrics. It's just not the standard. In my experience of watching teaching hospitals over the past 25 years, they've evolved into residents being taught mainly by maternal fetal medicine specialists who deal with almost everything they deal with is high risk. And so they're given the idea that a pregnant woman is a potential disaster, and so everything needs to be done to prevent the disaster, as opposed to reading the signs, watching the labor, and only intervening when the signs tell you that it's time to maybe do something different. As far as the baby goes, obviously a lot of it's theoretical. Nobody can ask a baby or interview a baby when it comes out and say, "Hey, how was that? Was that good?" You can use it's just common sense and experience. Well, when you see babies born through the midwifery model of obstetrics, you see a whole different scenario, not just in the parents, okay, and the bonding that goes on, but also in the alertness of the baby and the comfort of the baby and the less irritability of the baby. Now, does that make a long-term difference? I don't know how you know that. I don't know. Does a baby born by the midwifery model have a calmer nature when they're 25 years old? I don't think there's any study could possibly ever say that, but it just...
You don't think so? But it's possible? I know.
Well, I don't think there's any study that's ever shown that or proven that, because there's too many variables. You could never really do a study like that. But what I can say is common sense says if the baby's doing fine, leave them alone. Leave the baby alone. You don't need to suddenly rip the baby off its umbilical cord, or take the baby over to the warmer, or suction the baby out, or measure the baby's length, or throw the baby on a scale. Those things are not important. The important thing is, how is the baby breathing? What's the baby's skin color and pulse rate? If the baby seems to be calm and breathing fine, leave the baby alone. Just leave him alone. And as a matter of fact, when it comes to cord clamping, all the data suggests that not clamping the cord early makes most sense. For instance, what's the first thing we're trained to do as residents if a baby comes out a little bit depressed, a little bit floppy? The first thing we're supposed to do is cut the cord and hand the baby to the pediatrician or the neonatal person or the nursing people in attendance. Take the baby away from its placenta and hand it over there. Okay? If you think logically, why is a baby depressed when it's born? Well, it's depressed because one, it's either slightly hypoxic, which is lack of oxygen, or two, it's slightly hypovolemic because its cord has been getting compressed, its heart has been pumping blood away from it, the placenta gets engorged, the baby gets slightly less volume returning because the cord is being squished, and it squishes the veins more so than the arteries. And so the return to the baby is less, so the baby comes out a little bit hypoxic, a little bit hypovolemic. Okay? The best way to resuscitate a baby is to just leave it alone. Why would you cut it off from its source of blood volume and its source of oxygen? The placenta is still working when the baby's outside. But the mentality is, well, you got to clamp the cord and hand the baby over to the pediatricians, who then, what do? They give the baby oxygen. And if necessary, they'll stick a line in and give the baby volume if the baby's really suppressed, okay? Which the placenta would do naturally if you just leave it alone. And I have this from personal experience. Ever since I've read articles about this whole cord clamping, not cord clamping argument, in my own practice, I've noticed a huge difference. And even at C-section now, I got the nurses waiting for that baby. They're standing by the bed waiting for me to hand them the baby. And I'll let the baby sit there for 30 seconds, a minute, screaming away, okay? I'll have the father stand up, he can film. I let the cord go. I don't immediately clamp the cord because of what I've learned and what I've read. And it just defies common sense. There is no logic, other than a really severely depressed baby where there is no pulse pressure in the cord. If a baby is born when the very floppy and you feel the cord and you feel no pulse in the cord and there's no exchange going on, that baby needs to be dealt with by the newborn intensive care unit team.
So that would be the key?
Yeah, it's very rare. I mean, a baby has to be extremely depressed to have that happen. But most babies will come out a little bit depressed, and you'll see the nurses will be rubbing their back or the doctors flicking their feet. And you know, that's okay to try to stimulate them, but why do you need to separate them from their supply of oxygen and their supply of their own blood volume? What better volume expander is there than their own blood?